Hello and welcome. I am Yvette Cabasa, Pediatric Reimbursement Education Specialist for the Healthy Steps National Office. Thank you for taking the time to join us today for our third segment of the review of the California Healthy Steps Billing and Coding Guide, where the comprehensive perinatal service program and lactation services outside of the program will be examined in detail. As explained in the first and second segments of the guide's review, the presentation of the guide's entire contents is divided into four segments. In the first segment, we embarked on a journey filled with navigating through coding, billing, and documentation requirements for Healthy Steps aligned services by traveling on the California Billing and Coding Guide's Information Highway, where the journey ended with the review of smoking and tobacco use cessation. In the second segment, we continued in our travels and journeyed on Psychotherapy Road, where we learned about the different psychotherapy services open for Medi-Cal reimbursement. There, we explored the various session types and categories of patient medical necessity. We also delved into the service coding, billing, and documentation guidelines. For this segment, segment 3, we will continue in our travels on the Information Highway via the CPSP Parkway and Lactation Lane, where we will journey through understanding the Comprehensive Perinatal Service Program, which I will refer to as the CPSP throughout this segment. We will also explore lactation services when rendered outside of the program. And upon the conclusion of this segment, you will walk away knowing what is the CPSP and what are its policies, the services that fall under the program, the eligible providers and clinical settings that can render and bill for services, the coding and billing guidelines for CPSP services, including but not limited to the CPT codes, otherwise known as the billing codes, and the frequency limitations placed on the number of visits and/or the number of minutes that can be rendered. And I will end this segment with a review of lactation services when they are rendered outside of the CPSP. My goal today is to provide a clear interpretation of these services to facilitate compliant coding and billing to help your practice maximize revenue for Healthy Steps aligned services. And as you can see, we have quite a lot of information to review. So let's buckle up, place our learning vehicles into drive, and begin our drive on the CPSP Parkway leading to Lactation Lane. Let us begin with what is the CPSP with a little history of its origin. The California Department of Health Services implemented the CPSP in 1987. It is a program designed to provide enhanced prenatal and postpartum care to low-income pregnant and postpartum women. This program offers a range of services to pregnant patients from the date of conception and originally through 60 days after the month of delivery. But in response to the American Rescue Plan Act of 2021, the California Department of Healthcare Services expanded the postpartum care period from 60 days to 12 months. This change, which became effective on April 1st of 2022, is applicable to all Medi-Cal pregnant individuals. The 12-month postpartum period will begin on the last day of the patient's pregnancy and will end on the last day of the month in which the 365th day occurs. So now that we know a little history on the CPSP, let us begin our dive into the program's universal policies. For a practice to render CPSP services, they must have a Medi-Cal enrolled provider that has enrolled as a CPSP physician, and the CPSP physician must either render these services to patients or must provide personal supervision to those providers that are eligible to render the services. Personal supervision can occur through direct communication or via electronic means. Physicians must have a current provider number, most often referred to as a national provider number, shortened to NPI, and must complete an application to participate as a CPSP physician. For more information on the provider application process and on becoming a CPSC provider, a website link has been placed in the Billing and Coding Guide that contains a plethora of information on the program, and it includes information about the application process as well as provider resources. The providers, otherwise referred to as practitioners, that are eligible to render CPSP services are physicians, certified nurse midwives, licensed midwives, registered nurses, licensed vocational nurses, nurse practitioners, physician assistants, health educators, certified childbirth educators, registered dietitians, and registered dietitian nutritionist consultants, comprehensive perinatal health workers, social workers, psychologists, and marriage and family therapists. These eligible providers must have at least 1 year of experience in perinatal care prior to rendering CPSP services. Note that although recognized by Medi-Cal to render lactation services, international board certified lactation consultants were not included on the list of providers that are eligible to render these services. Because of this, I highly recommend verifying with Medi-Cal and other insurance carriers your site participates with on if lactation consultants can render those CPSP services that fall under their certification scope of practice. And for those providers that do not possess a license, verification on the education and credentialing requirements must be made with either your administrative staff, your practice's CPSP physician, or your local perinatal services coordinator at your local county health jurisdiction. Regarding the clinical settings eligible to render and bill for CPSP services, hospital outpatient settings, including community or county outpatient settings, group medical practices, alternative birthing centers, federally qualified health centers referred to as FQHCs, and rural health centers referred to as RHCs are all recognized for Medi-Cal reimbursement for CPSP services. To continue with the program's universal policies, there are services that are not included to be provided, which are inpatients, and they are not intended to replace the services that are part of the American College of Obstetrics and Gynecology visit standards, as these services would be in addition to or an enhancement of services. All patients receiving CPSP services must provide consent to receive all of the program's enhanced services, which can be done verbally and noted on the CPSP forms. Also, these services can be rendered via telephone and other telehealth modalities under the California's COVID-19 state of emergency guidelines. But once these guidelines have been lifted, please verify with your insurance carriers on if reimbursement will be recognized for CPSP services when rendered via any of the approved telehealth avenues of delivery. And the last but not the least of the program's universal policies is how treatment authorization requests, otherwise referred to as TARs, are not required for the billing and rendering of CPSP services unless exceeding the allowable maximum units of service. If TARs are not required at your practice, as seen in FQHCs and RHCs, chart documentation for additional CPSP services must include the same justification necessary as when obtaining a TAR. This now brings us to the end of the program's universal policies, and now I will slow down on the CPSP Parkway to begin the review of its services. CPSP services are divided into three service types. The first are nutritional counseling services. The second are health education services. And the third are psychosocial services. Let us look at the elements of service under each service type to better understand the full range of these services and what category of service they fall under. First, let us look at nutritional counseling services. Nutritional counseling services are very important to ensure the optimal health of both the mother and the infant. Ongoing nutritional counseling services are critical in a woman's perinatal care. Nutritional counseling services include an initial assessment and follow-up nutrition reassessments for each trimester, prescription services for prenatal vitamins, and education and intervention services if nutritional problems were detected in the assessment. Assessments, reassessments, and interventions are carried out by designated and trained CPSP practitioners and should occur at the initial assessment, trimester reassessments, postpartum visit, and any time necessary within the allowable units of service that Medi-Cal will reimburse for. Now, although not a requirement, including registered dietitians and/or registered dietitian nutritionists on the CPSP team is encouraged, as these healthcare providers are specifically qualified to provide nutritional services, including education for patients, as well as technical assistance to other CPC members rendering these services. Continuing with nutritional services, medical nutrition therapy may also be provided to women presenting with complex medical conditions, which may require more in depth nutrition assessment, diet modification, frequent monitoring, and revision of the patient's nutritional care plan. Rendering medical nutrition therapy may be required by a registered dietitian or registered dietitian nutritionist, so I recommend verifying with insurance carriers on the professionals they will recognize for the reimbursement of medical nutrition therapy. And last of the services that fall under nutritional counseling is the need for an individualized care plan addressing the patient's needs and goals. This now brings us to the second of the three CPSP service types, which are health education services. Pregnancy creates new learning needs for women, which may include accurate health and perinatal care facts, active learning for specific behavioral changes, and the practice of new skills or modification of current habits for optimum health. Health education services include an initial assessment, which identifies current health practices, strengths, and health education needs. And it also includes an initial orientation, ongoing training in health education during the entire perinatal period to enforce the information that is initially provided to help understand new procedures, tests, or services so that a patient's consent and participation will reflect her being informed. And just as seen with the elements of service for nutritional counseling services, an individualized care plan is also included in health education services. Health education care plans should include health education objectives that specify the health education services and interventions the patient will receive to meet her needs. Additionally, subsequent trimester and postpartum reassessments are also part of education assessments and services, where the trimester and postpartum reassessments are used to evaluate the effectiveness of the health education services provided, where evaluation of the patient's progress towards achieving the health education objectives is also done. Adjustment to the care plan should be done as necessary, as well as evaluations of patients' satisfaction. Protocols that include topics such as prenatal care, self care, the progress of pregnancy, fetal development, labor and delivery, postpartum care, safety topics, infant care, and common conditions in pregnancy should also be reviewed and visited often. And last of the elements of service under health education services are health interventions, which include individual, small group, and class sessions provided throughout the prenatal period to the end of the postpartum period. So now that we have explored the elements of service that fall under nutritional counseling services and health education services, let us now conclude this area of exploration with the third CPC service type, psychosocial support services. Psychosocial support services help patients to understand and effectively handle emotional, biological, and the social stresses of pregnancy. Psychosocial care assists women with transportation needs, community resources, crisis intervention, or any psychosocial problem affecting her care. Although not required, including a social work professional on the CPSP team is encouraged, as these healthcare providers are specifically qualified to provide psychosocial services and support to patients. Psychosocial services include an initial psychosocial assessment, which is used in determining the impact that social, emotional, and economic issues and needs have on a woman during her pregnancy. Psychosocial reassessments are also included in psychosocial services. Reassessments should be provided every trimester and in the postpartum period, where many of the problems presented can be improved by brief social service interventions. And last of the elements of service under psychosocial services are psychosocial interventions. Psychosocial interventions, which are usually provided for those problems discovered during an assessment, are directed at assisting the patient to understand and effectively manage the emotional, biological, and social stresses of a pregnancy. Now that I have reviewed all the CPSP service types and the elements of service within each, you are probably wondering where lactation services lie as lactation services, also referred to as breastfeeding services, should be included in a program designed to provide enhanced prenatal and postpartum care. And that would not be incorrect, as it should and it does. Breastfeeding services are included in the CPSP and are in fact recognized under all CPSP service types and all of the elements of service within each type. Nutritional counseling, health education, and psychosocial services are also applicable to breastfeeding services when the nutritional counseling, health education, and psychosocial services rendered are centered around breastfeeding. Education and support for breastfeeding is another aspect of basic nutrition, health education, and psychosocial supports. And because Medi-Cal and managed care carriers recognize breastfeeding promotion, education, and counseling services, they will reimburse for all CPSP services when rendered due to any of the aspects of breastfeeding. This now concludes my review of nutritional counseling, health education, and psychosocial service supports under the CPSP, but there are additional services available to pregnant and postpartum women under the program. Services such as antepartum and postpartum medical visits, and services that incorporate providing the initial assessments for all three CPSP services within 4 weeks of a patient's entry into care. We will examine these additional services when reviewing the coding and billing guidelines for CPSP services, which I will review next. This now brings us to the end of my review of the three CPSP service types and the elements of service under each. It has been a nice, smooth ride so far, and I do not anticipate any traffic up ahead, but I do anticipate some speed bumps as we are about to embark on the portion of the CPSP parkway that travels via coding and billing guidelines for CPSP services, where there is much information to absorb. So, without further hesitation, let's continue this journey and review the billing and coding guidelines for CPSP services. Billing for nutritional health education and psychosocial services comes with its own unique set of billing codes, guidelines, and frequency limitations. It also comes with reimbursement guidelines, which I will review first. Reimbursement for obstetric services is the same for all Medi-Cal providers, where services can be billed globally, which is when obstetric services are billed once, utilizing the appropriate billing code that represents the antepartum care, the delivery, and the postpartum care of a patient. This means that for a provider to bill globally, he or she must render total obstetric care, which again is the antepartum care, the delivery, and the postpartum care of the patient. But providers can also bill on a per visit basis if not rendering total obstetric care to the patient, which includes if a patient transfers care during her pregnancy. With regard to nutritional health education and psychosocial services delivered under the CPSP, providers cannot bill globally and only on a per visit basis. Certain clinical settings, such as FQHCs and RHCs, are paid at a flat fee rate per visit as defined in the Medicaid prospective payment system, where the reimbursement of one flat rate for one visit per day still applies. Additionally, Medi-Cal guideline reflects that the billing of CPSP services for those FQHC and RHC patients under a managed care plan must be done by first billing the managed care plan, and then Medi-Cal should be billed for the remainder of the prospective payment system rate. The FQHC and RHC billing guidelines was published by Medi-Cal with no other information. If further information or further explanation is needed, verification with Medi-Cal at the site level is required. Continuing with reimbursement guidelines, case coordination is also a CPSP service and is provided during initial assessments and the development of care plans for the three CPSP services, which again are nutritional services, health education services, and psychosocial support. And a one-time case coordination fee is available when the initial assessments and care plans for all three of these services are completed within 4 weeks of the comprehensive obstetric visit. More information regarding eligibility for the one-time case coordination fee and how to obtain it must be obtained in the CPSP training that is offered to all sites and practices that have CPSP enrolled providers. When not billing for all three initial assessments simultaneously, because they may have not been rendered within 4 weeks of the comprehensive obstetric visit, Billing for the initial assessments should be done individually. Another reimbursement guideline revolves around the billing and reporting of the allowable units of service that insurance carriers will reimburse for. Most CPSP services are time based, meaning that in the service code's description, there is an indication of a minimal time requirement for the billing of those services. Of those CPSP services that are time based, some indicate to either be billed in 15-minute increments or in 30-minute increments, where these increments are represented by the units of service reported when billing. Medi-Cal advises that when billing for CPSP services, the CPT time rule, sometimes referred to as the midpoint rule, is applicable. This rule was explained in Segment 2 of the Coding and Billing Guide when psychotherapy services were reviewed. But to recap, the CPT time rule allows for services to be billed for less time than indicated in the code's description of services. Medi-Cal advises that this reimbursement rule is recognized when billing for those CPSP services with 15-minute increments, where those indicated to be billed for 30-minute increments are not eligible. When we later review the billing codes for these services, I will assess with how the rule is applied and how to calculate units of service based on this rule. And last of the guidelines for review is regarding the diagnoses that will support the medical necessity for CPSP services. When billing for CPSP services, a pregnancy diagnosis selected according to the patient's trimester at the time of the CPSP visit should be the primary diagnosis. And if rendering services during the patient's postpartum period, a postpartum diagnosis must be the primary diagnosis. Additionally, any condition or conditions applicable to the patient and the CPSP services being rendered should also be diagnosed, including codes for social drivers of health, otherwise known as social determinants of health when applicable. This concludes reimbursement guidelines, which now puts us in a good place on this journey to review the billing codes. I will first review the codes and their descriptions and will follow with the frequency limitations placed on services, also known as the maximum units of service, that can be rendered during a patient's pregnancy and postpartum period, and will include how to calculate and report the units of service. So let us begin reviewing the codes and their descriptions. First set of codes for review are those that pertain to the billing of nutritional services referred to as nutritional counseling services. There are 5 billing codes for the reporting of these services, where one is an add-on code. And for those of you that have already listened to the first and second segments of the 4 segmented review of the guide, you are aware of what add-on codes are. But for those of you who had not had the opportunity to listen to the segments yet, here's a quick recap. Add-on codes are codes that can only be billed in conjunction with another code or codes. Therefore, they are not independently billable, meaning they cannot be billed by themselves. Add-on codes can be thought of as buddy codes, created to be partnered and billed with other codes they are designed for, which are referred to as their primary codes, making them codes that represent an extension of their services. Now that we know what add-on codes are, let us examine the 5 billing codes for nutritional services. The first of the 5 billing codes is Z6200. Z6200 is for the billing of the initial nutrition assessment and development of the patient's care plan. It is designated to be billed for the billing of the first 30 minutes of service, meaning it is for the billing for the first 30 minutes taken to render these services to the patient. And when looking to the maximum units of service that can be billed during a patient's pregnancy and postpartum period, you will see that only one unit can be billed, indicating that this code can only be billed once during a patient's pregnancy and postpartum period. The second of the 5 codes is Z6202. The description of billing code Z6202 reads as initial nutrition assessment and development of care plan each subsequent 15 minutes. Z6202, just as Z6200, is also for the billing of an initial assessment and development of the patient's care plan, but it is indicated to be for the reporting of 15 subsequent minutes of service. You may be asking yourself, what does this mean? Well, Z6202 is an add-on code. And what did we say about add-on codes? Add-on codes are codes created to be partnered with another code or codes, and they can never be built by themselves. They serve as buddy codes, an extension of services to the primary code they have been assigned to and created for. You also may be asking yourself, how would you know that Z6202 is an add-on code? Well, when looking at the description for Z6202, the word subsequent is used. And what does using the word subsequent indicate? It indicates that these 15 minutes are following other minutes. Therefore, this is an indication that these services are only services that follow another. And when looking at the description of Z6200 and Z6202, you can clearly see that Z6202 is an extension of Z6200, consequently created to be built in conjunction with it. Z6202 is only to be reported with Z6200 if additional time was spent rendering the service after the initial 30 minutes of time was spent. And when looking to the maximum units of service that can be billed during a patient's pregnancy and postpartum period for this add-on code, you see that the maximum number of units that can be billed during a patient's pregnancy and postpartum period is 6. This does not mean that you can bill for 6 separate visits, but only that you can bill for up to 6 units of service. And how would we know this? Well, when reporting units of service for an add-on code, it is important to remember that add-on codes do not stand on their own and are only an extension of their primary code. And because Z6202 is an extension of its primary code, Z6200, which can only be billed during a patient's pregnancy and postpartum period, then Z6202 can also only be billed once during a patient's pregnancy and postpartum period, but up to 6 units of service can be billed for, which in this case are units of time and not days. When we examine how to calculate units of time after this review of the billing codes, I will dive deeper into how you would calculate units of time for compliant billing practices. Next of the billing codes is Z6204. Z6204's description reads, follow-up antepartum nutrition assessment, treatment and/or intervention, individual each 15 minutes. Z6204 is the code that represents the billing for these services when rendered to an individual patient. And when looking at the maximum units of service that can be billed during a patient's pregnancy and postpartum period, you will see that up to 8 units of service can be reimbursed for. Z6404 is not an add-on code, but a code that can stand on its own. So when it relates to maximum units of service that can be billed during a pregnancy and postpartum period, it can be units of time provided on a given date of service, or it may be able to be divided into different dates of service, as long as you do not bill for more than the maximum time indicated. The fourth code for the billing of CPSP nutrition services is Z6206. Z6206 description reads, follow-up antepartum nutrition assessment, treatment and/or intervention group per patient for each 15 minutes. Billing Z6206 indicates that you are billing for group sessions comprised of at least 2 patients or more, where Z6206 is to be billed for each patient who participates in the group. And when looking at the maximum units of services that can be billed during a patient's pregnancy and postpartum period, you will see that up to 12 units of service can be reimbursed for. Z6406 is not an add-on code, but a code that can stand on its own. So when it relates to maximum units of service that can be billed during a pregnancy and postpartum period, it can be units of time provided on a given date of service, or it may be able to be divided into different dates of service, as long as you do not bill for more than the maximum time indicated. This now brings us to the last billing code for CPSP nutritional services, the fifth code, which is Z6208. The description of billing code Z6208 reads as postpartum nutrition assessment, treatment and/or intervention, including development of care plan, individual each 15 minutes. Z6208 is for the reporting of visits that are conducted after the baby is born, and they are for nutritional assessments, treatments, and/or interventions, and also includes development of a care plan per individualized patient, which means the services are only for the mother. When looking at the maximum units of service that can be billed during a patient's postpartum period, you will see that up to 4 units of service can be reimbursed for. Z6208 is not an add-on code, but a code that can stand on its own. So when it relates to the maximum number of units of service that can be billed during a pregnancy, or in this case, the postpartum period, the maximum allowable units represents units of time provided on a given date of service, or it may be able to be divided into different dates of service, as long as you do not bill for more than the maximum time indicated. This concludes my review of the billing codes for CPSP nutritional services. So let us now review the billing codes for psychosocial supports. And just as seen with nutritional services, there are also 5 billing codes, where one is an add-on code. The first of the 5 billing codes is Z6300. Z6300 is for the billing of the initial psychosocial assessment and development of a patient's care plan. It is indicated to be billed for the first 30 minutes of service, meaning the first 30 minutes taken to render these services to the patient. And when looking at the maximum units of service that can be billed during a patient's pregnancy and postpartum period, you will see that only 1 unit can be billed, indicating that this code can only be billed once during a patient's pregnancy and postpartum period. The second of the 5 psychosocial support service billing codes is Z6302. The description of this code reads as initial psychosocial assessment and development of care plan each subsequent 15 minutes. Z6302 is also for the billing of an initial assessment and development of the patient's care plan, but it is indicated to be for the reporting of 15 subsequent minutes of service, indicating it is an add-on code. When looking at the description of Z6302, you can see that it was clearly created to be billed in conjunction with Z6300, as its service description is the exact same service description for code Z6300, with only one difference, it being that it is for the reporting of subsequent time, meaning time in addition to another. And when looking at the maximum units of services that can be billed during a patient's pregnancy and postpartum period, you will see that the maximum number of units that can be billed is 6. This does not mean that you can bill for 6 separate visits, but only that you can bill for 6 units of service. And how would we know this? Because just as explained when reviewing add-on code Z6202, when you are reporting units of service for an add-on code, it is important to remember that add-on codes do not stand on their own and are only an extension of the services of their primary code or codes. And with regard to Z6302, its primary code is Z6300, whose maximum number of billable units during a patient's pregnancy and postpartum period is 1. Therefore, Z6302 can only be billed once during a patient's pregnancy and postpartum period, but up to 6 units of service can be billed for on that one date of service. So in this case, units of service are units of time and not units that represent dates of service. Again, when we cover how to calculate units of time after this review of the billing code, I will dive deeper into how you will calculate units of time for the compliant billing for these time-based codes. Next of the billing codes is Z6304. Z6304's description reads, follow-up antepartum psychosocial assessment treatment and/or intervention, individual each 15 minutes. Z6304 represents the billing for follow-up antepartum psychosocial assessments, treatments, and/or intervention services when rendered to an individual patient. And when looking at the maximum units of service that can be billed during a patient's pregnancy and postpartum period, you will see that up to 12 units of service can be billed for. Z6304 is not an add-on code, but a code that can stand on its own. So when it relates to maximum units of service that can be billed during a pregnancy and postpartum period, it can be units of time provided on a given date of service, or it may be able to be divided into different dates of service, as long as you do not bill for more than the maximum time indicated. The fourth code for the billing of CPSP psychosocial services is Z6306. Z6306's description reads, follow-up antepartum psychosocial assessment treatment and/or intervention group per patient for each 15 minutes. Just as with billing code Z6303, Z6306 also represents the billing for follow-up antepartum psychosocial assessments, treatments, and/or intervention services, but when rendered in a group setting. Medi-Cal guidelines advise that a group setting must be comprised of at least two patients or more, where Z6306 is to be billed for each patient who participates in the group. And when looking at the maximum units of service that can be billed during a patient's pregnancy and postpartum period, you will see that up to 16 units of service can be billed. And because Z6306 is not an add on code, but a code that can stand on its own, maximum units of service can represent units of time provided on a given date of service, or it may be able to be divided into different dates of service as long as you do not bill for more than the maximum time indicated. This now brings us to the last billing code for CPSP psychosocial services, the fifth code, which is Z6308. The description of billing code Z6308 reads as postpartum psychosocial assessment, treatment, and/or intervention, including development of care plan, individual each 15 minutes. Z6308 is for the reporting of these services when conducted after the baby is born. And when looking to the maximum units of service that can be billed during a patient's postpartum period, you will see that up to 6 units of service can be billed for. And because Z6308 is not an add on code, but a code that can stand on its own, units of service represent either the billing for units of time provided on a given date of service, or it may be able to be divided into different dates of service, as long as you do not bill for more than the maximum time indicated. This concludes my review of the billing codes for CPSP psychosocial support services, which brings us to the review of the billing codes for comprehensive health education services, where unlike nutritional and psychosocial support services, where there are 5 billing codes under each service, health education services have 8 codes where one is an add-on code. The first of the 8 billing codes for the billing of comprehensive health education services is Z6400, whose description reads as client orientation health education each 15 minutes. This code is for the billing of health education orientation provided to a patient either during their pregnancy and/or their postpartum period. And when looking at the maximum units of service that can be billed during a patient's pregnancy and postpartum period, you will see that up to 8 units of service can be reimbursed for. Z6400 is not an add on code, but a code that can stand on its own. So when it relates to maximum units of service that can be billed during a pregnancy and postpartum period, it can be units of time provided on a given date of service, or it may be able to be divided into different dates of service, as long as you do not bill for more than the maximum time indicated. The second of the 8 billing codes for comprehensive health education services is Z6402. Z6402's description reads as Initial Health Education Assessment and Development of Care Plan, first 30 minutes. And it is for the billing of these services rendered either during the patient's pregnancy or postpartum period. And when looking at the maximum units of service that can be billed during a patient's pregnancy and postpartum period, you will see that only 1 unit can be billed, indicating that this code can only be billed once during a patient's pregnancy and postpartum period. The third billing code for comprehensive health education services is Z6404. The description of billing code Z6404 reads as Initial Health Education Assessment and Development of Care Plan, each subsequent 15 minutes. And as with billing code Z6402, Z6404 is also for the billing of an initial assessment and development of the patient's care plan, but it is indicated to be for the reporting of 15 subsequent minutes of service. And since this code's description reads exactly the same as Z6402's description, with the exception of it being for the reporting of subsequent minutes, you know that Z6404 is an add-on code, where Z6402 is its primary code, meaning it can only be reported in conjunction with it. And when looking at the maximum number of services that can be billed during a patient's pregnancy and postpartum period, you see that the maximum number of units is 8. Can someone tell me if this means that you can bill for up to 8 separate visits? If the answer is no, you are correct. Remember how when reporting units of service for add-on codes is important for you to consider that add-on codes do not stand on their own and are only an extension of their primary code or codes. Well, Z6404's primary code is Z6402, which can only be billed once during a patient's pregnancy or postpartum period. Therefore, its add-on code Z6404 can only be billed once as well during a patient's pregnancy and postpartum period, but up to 8 units of service can be billed for, which in this case are units of time and not dates of service. Next of the comprehensive health education billing codes is Z6406. Z6406's description reads as follow-up antepartum health education assessment treatment and or intervention individual each 15 minutes. Z6406 is the code that represents the billing for these services when rendered to an individual patient. And when looking at the maximum units of service that can be billed, you will see that up to 8 units of service can be reimbursed for during a patient's pregnancy. Z6406 is not an add-on code, but a code that can stand on its own. So when it relates to maximum units of service that can be billed during a pregnancy and postpartum period, it can either be units of time provided on a given date of service, or it may be able to be divided into different dates of service, as long as you do not bill for more than the maximum time indicated. The fifth code for the billing of comprehensive health education services is Z6408, whose description reads follow-up antepartum health education assessment, treatment and/or intervention group per patient for each 15 minutes. This code also represents the billing for follow-up antepartum health education assessment, treatments, and/or intervention services, but when rendered in a group setting, comprised of at least 2 patients or more, where Z6408 is to be billed for each patient who participates in the group. And when looking at the maximum units of services that can be billed during a patient's pregnancy, you will see that up to 8 units of service can be reimbursed for. And because Z6408 is not an add-on code, but a code that can stand on its own, the maximum units of service that can be billed can either be units of time provided on a given date of service or may be divided into different dates of service as long as you do not bill for more than the maximum time indicated. This now brings us to the sixth billing code for comprehensive health education services, which is Z6410, whose description reads as perinatal education individual each 15 minutes. And when looking at the maximum units of services that can be billed, you will see that Medi-Cal has provided very specific guidance where it is indicated that up to 16 units per day can be billed, with a maximum of 72 units in total that can be billed during a patient's entire pregnancy. Z6410 is not an add-on code, but a code that can stand on its own. So when it relates to maximum units of service that can be billed, it can either be units of time provided on a given date of service, or it may be able to be divided into different dates of service as long as you do not bill for more than the maximum time indicated. And the final code for the billing of comprehensive health education services is Z6414, whose description reads as postpartum health education assessment, treatment, and/or intervention, including development of a patient's care plan, individual each 15 minutes. Z6414 is for the reporting of these services, but when it is conducted during a patient's postpartum period. And when looking at the maximum units of service that can be billed during a patient's postpartum period, you will see that up to 4 units of service can be reimbursed for. And because Z6414 is not an add-on code, but a code that can stand on its own, its maximum units of service can be units of time provided on a given date of service, or it may be able to be divided into different dates of service as long as you do not bill for more than the maximum time indicated. This concludes the review of the billing codes and their descriptions for nutritional counseling services, psychosocial support services, and comprehensive health education services under the Comprehensive Perinatal Services Program, the CPSP. But before I move on to another set of reimbursable codes for CPSP services, I will remind you that all three of these services can also be applied to breastfeeding. In addition, the guidance for the required documentation for CPSP services is based on the information stated as needed on the appropriate CPSP forms for the services rendered. Information on how to obtain these forms for the documentation can be retrieved from the website link provided in the CPSP section of the Billing and Coding Guide. Let us now review the codes that are relevant to the additional services that can be provided under the program. In addition to nutritional, psychosocial support, and comprehensive health education services, antepartum and postpartum medical visits are also part of the CPSP, where three billing codes are recognized for the reimbursement of related services. The first service related to antepartum and postpartum medical visits is the initial antepartum office visit when performed within 16 weeks of the patient's last menstrual period. This service can be billed if a patient's very first obstetric visit occurs within 16 weeks of their last menstrual period, even if the patient declines CPSP services, as long as the provider's documentation clearly indicates that the services were indeed offered but refused. Antepartum and postpartum medical visits can be rendered by those medical professionals authorized to render medical services under their scope of practice. Of those practitioners authorized to render CPSP services, OBGYN physicians, certified nurse midwives, nurse practitioners, and physician assistants are those that can render antepartum and postpartum medical visits as long as the OBGYN specialty is under their scope of practice. The billing code for the initial antepartum office visit performed within 16 weeks of the patient's last menstrual visit is Z1032. And when looking at the maximum units of service that can be billed during a patient's pregnancy, you will see that only one unit can be billed, indicating that this code can only be billed once during a patient's pregnancy. But there is an additional billing guidance provided by Medi-Cal that is important to the correct and successful billing of this code. Medi-Cal advises of the need to report medical coding modifiers when billing for an initial antepartum office visit performed within 16 weeks of the patient's last menstrual period. Medical coding modifiers, referred to simply as modifiers, are two characters comprised of either letters or numbers that are appended to billing codes upon claim submission to insurance carriers. Modifiers provide additional information about a billing code without changing the meaning or description of the code. Example of why billing modifiers were created is to report if a procedure performed involves more than one anatomical location or if a procedure was bilateral. Also, if the services were rendered by more than one provider or if a service or procedure was increased or reduced in comparison to what the code typically requires, and modifiers are also used to identify the provider type rendering the service, which is why the reason Medi-Cal requires a modifier for the billing of Z1032. When submitting claims to Medi-Cal, identifying whether either a physician, a certified midwife, a physician assistant, and a nurse practitioner renders the service is a requirement, and this identification is done via the appendage of a modifier. Let us quickly review the required modifiers for each of these provider types before we move ahead to the second of the three billing codes for antepartum and postpartum medical visits. Modifier ZL must be appended to billing code Z11032 when a physician renders the initial antepartum visit. Modifier SB must be appended when a certified nurse midwife renders the service. Modifier U7 must be appended when a physician assistant renders the service, and modifier SA must be appended when a nurse practitioner renders the service. And in addition to modifiers SB, U7, and SA, when billing for either a certified nurse midwife or a physician assistant or a nurse practitioner, you must also append a modifier 99 when billing for the initial medical antepartum office visit when services are rendered by these professionals. Notice that appending the additional 99 modifier is not a requirement when billing for a physician. This is because Medi-Cal guidelines advise that appending modifier 99 is not a requirement when billing for a physician. Now let us review the second billing code for the reporting of antepartum and postpartum medical visits, which is Z1034. Z1034, just as when billing Z1032, is also for the reporting of antepartum medical visits, but Z1334 is different. It is for the billing of the second antepartum visit through the 14th, whereas the billing of Z1032 is for the billing of the initial visit only. Z1034 cannot be billed until Z1032 has been billed. And when looking at the maximum units of service that can be billed during a patient's pregnancy, you will see that 13 units can be billed, where in this case, Medi-Cal has specified that 13 units represent 13 visits. Additionally, Medi-Cal has also advised that this code can only be billed by a CPSP physician. This brings me to the last of the three billing codes for antepartum and postpartum medical visits under the CPSP, which is Z1038. Z1038 is for the reporting of a postpartum medical visit, which can only be billed by a CPSP physician. Medi-Cal does not provide specific direction on the maximum number of units that can be billed for postpartum visits, so insurance carrier verification is required. And this concludes my review of antepartum and postpartum medical visits under the CPSP, which brings me to the last two additional services that can be provided and billed for under the CPSP, which are the billing for prenatal vitamin prescription services and the billing for when all three initial assessments and development of a patient's care plan are provided simultaneously within 4 weeks of a patient's entry into care. Let us first review the billing code for prenatal vitamin prescription services, which is S0197. S0197 is for the billing of prenatal vitamin services when a 30-day supply has been prescribed by a provider during the rendering of nutritional services. This is an indication that S0197 can only be billed when billing for any of the codes that fall under nutritional services. 1 unit of service represents each 30-day prescription supplied to the patient per date of service. And if you look at the maximum number of units that can be provided during a patient's pregnancy, you will see that 10 units can be billed, indicating that you can bill S0197 for 10 visits, as long as it is billed with a nutrition service code when rendering a 30-day prescription for prenatal vitamins. And last of the additional billing codes for review is Z6500. Z6500 is not an additional service under the CPSP, but rather a combination of services that, when rendered simultaneously, would be billed using one billing code, Z6500. The description for this code reads as Initial Comprehensive Nutritional, Psychosocial, and Health Education Assessments and Development of Care Plan when rendered within 4 weeks of entry into care, individual for the first 30 minutes of each assessment, including ongoing coordination of care. Z6500 is for the reporting of these services when all three are rendered within 4 weeks of a patient's entry into OBGYN care, and if the initial pregnancy related exam was also completed within the same 40-week period. When billing for this code, you are billing for 90 minutes of care, as the billing code for each initial assessment is for the billing of 30 minutes of service. And unlike three individual codes for the three different initial assessments and development of care plans, this code can only be billed once during a patient's pregnancy and postpartum period. This concludes my review of the billing codes for CPSP services, which brings us to a rest stop on the road, where I will take the opportunity to provide a deeper dive into how you would calculate and bill for units of service when reporting CPSP services. Before I begin, let us take a moment to journey back in time to when I reviewed the reimbursement guidelines for CPSP services. There, I advised that Medi-Cal recognizes the time rule, sometimes referred to as the midpoint rule, for the reimbursement of the units of service when reporting CPSP services. Let us review this rule, what it means, and how to apply it when calculating and reporting units of service for a given CPSP service. The time rule, again, also referred to as the midpoint rule, indicates that a unit of time can be reported when a provider has rendered services for more than half the time indicated in the description of the time based code. Time based codes are codes whose descriptions include an exact time requirement or a range of time that the service can be billed for, but the time rule is only applicable when the description of a code provides an exact time and not a range of time. The time rule indicates that if at least more than half of the time allotted in a code's description is spent rendering the service, then the provider can bill for that code. Insurance carriers have the option of either adopting this rule for all time based codes or some time based codes, and they also have the option of not recognizing the rule at all. Though not accepted by all payers, even CMS allows the application of this rule for some of the time based service codes, and Medi-Cal has advised of their recognition and adoption of the time rule for CPSP services, but only for those CPSP services whose billing codes indicate they are for the reporting of 15-minute increments of time. With this said, keep in mind that Medi-Cal will not recognize the application of the time rule for any code that indicates it is for the reporting of 30 minutes of service, as seen with the initial assessments and development of care plans under each service category indicated to be billed for the first 30 minutes. For clarity, in the CPSP section of the National Office Billing and Coding Guide, you will find that we have listed the billing codes where the time rule can be applied and separately listed those where it cannot. Additionally, the guide provides how Medi-Cal calculates units of service, but I will review this with you, referring to the contents in the guide for added assistance in understanding this technique. Now, because the time rule advises that you can bill for certain time-based codes when at least more than half the time allotted in a code's description was spent rendering the service, and Medi-Cal advises of their adoption of this rule for those CPSP services that are indicated to be billed for 15-minute time increments, then when reporting the codes whose descriptions indicate they are for the billing for 15-minute increments, you can actually bill for them when at least 8 minutes or more was spent rendering the service. For example, when billing for follow-up antepartum assessments, treatments, and interventions, which are services whose description indicates them to be billed for each 15 minutes, you can still bill for the services if at least 8 minutes was spent rendering them. Now that we know this, how would you calculate the number of units to be billed when billing for these 15-minute services that can now be billed when 8 minutes of services are rendered? Well, Medi-Cal does provide specific guidance for the calculation and billing for the units of CPSP services when applying the time rule. And because this information is in the coding and billing guide, let us refer to the guide to assist us in providing clarity on how this calculation is done. The CPSP services portion of the guide contains a table in the Calculating Billing Units for Time-Based Code subsection, where you find a table with the same heading that is comprised of 2 columns with 4 rows. Let us look at this table now. The first column, headed as Time Rendering Care, represents the amount of time a provider must spend with the patient rendering the care that pertains to the billing code being reported. The second column, headed as Billable Units for Time Spent Rendering Care, represents the number of units you would bill for according to all the time the provider has spent rendering the care to the patient. Let's take a closer look at this by reviewing each row individually. The first of the 4 rows advises that if the provider renders the service for less than 8 minutes, the services are not reimbursable and therefore should not be billed to the insurance carrier. The second row advises that if the provider spends between 8 and 22 minutes rendering the service to the patient, then 1 unit of service should be reported and billed for. The third advises that if the provider spends between 23 and 37 minutes rendering the service to the patient, then 2 units of service would be reported and billed for. And the fourth row advises that the provider spends between 38 and 51 minutes rendering the service to the patient, then 3 units of service would be billed for. And directly underneath the last row, you find the billing codes that the time or midpoint rule are not applicable to, which again are codes whose descriptions advise that they are for the billing of 30 minutes of service. Now, regarding any time spent rendering services for more than 51 minutes, Medi-Cal guidelines did not provide specificity on this, But national coding guidelines advise that once 52 minutes of service has been rendered, you can bill for the full hour of service. Let's look at one of the billing codes to help you further understand this. Let's look at billing code Z6204. Z6204 is for the billing of follow-up antepartum nutrition assessments, treatments, and/or interventions for an individual patient for the billing of each 15 minutes, where a maximum of 8 units of service can be billed during the patient's pregnancy. If a provider has spent at least 8 minutes with the patient and a maximum of 22 minutes rendering the service indicated to be billed for the reporting of Z6202, then he or she would bill for 1 unit of service. If the provider spends at least 23 minutes and up to 37 with a patient rendering the services, then 2 units of service would be billed for. And just as the table indicates, if the provider spends 38 minutes and up to 51 minutes rendering the services to the patient, then 3 units of service can be billed for. Now, once the provider spends 52 minutes rendering services to a patient, they can bill for the units that are equal to 1 hour. And since each unit of service is indicated to be billed for the reporting of 15 minutes, then 4 units of service are equivalent up to 1 hour of service. Using the same billing code, let us look at how calculating these units of service can also be done over 2 or 3 visits. Calculating the time for the reporting of units when the services are provided on 2 or 3 different visits does not change, but keeping track of the number of units of service you are billing for is important, as you should not exceed the maximum allowed unless a treatment authorization request, otherwise known as a TAR, is approved, where medical necessity for the additional units of service will be supported. Let us take a look at how billing can be done over various states of service utilizing the same billing code. Let's say a provider sees a patient in March and renders services for an antepartum nutrition assessment treatment and/or intervention and spends 60 minutes with the patient rendering the services. And the same patient is seen in June, where the provider also renders the same service but spends 45 minutes with the patient rendering the services. Well, then 1 unit of service for billing code Z6402 would be billed for March's date of service. And when billing for June's date of service, 3 units of service would be billed for. Consequently, between March's date of service and June's date of service, 4 units of service were billed for. And when looking to the maximum number of units that can be billed during a patient's pregnancy for the services represented in billing code Z6402, you see that the allowable number of units are 8. Therefore, since you have already billed for 4 units, an additional 4 units of service can be billed and reimbursed for when billing these services during the patient's pregnancy. This now ends the review on how to calculate the number of units of service when billing for CPSP services, where the time rule, also known as the midpoint rule, is applicable for services designated for the billing of 15 minutes per billable unit. And although this concludes my review of the Comprehensive Perinatal Services Program, our journey today does not end here, as we will now look at the billing and coding guidelines for lactation services when they are rendered to those patients that are not enrolled in the CPSP program. So let us exit off the CPSP Parkway and merge onto Lactation Lane, where we will journey through information on breastfeeding services when provided outside of the Comprehensive Perinatal Services Program. Medi-Cal reimburses for breastfeeding services both within the Comprehensive Perinatal Services Program and outside of the program for those patients that have either declined CPSP services or are not eligible for the program. Although Medi-Cal's website offers very little guidance on breastfeeding services when rendered outside of the CPSP, the minimal information they do provide will assist you in understanding the billing and coding nuances for the reporting of lactation services when rendered outside of the CPSP. By the end of our journey on Lactation Lane, you will know the provider types that are eligible to bill for the services, billing codes used to report the services rendered, the umbrella of diagnoses that will support medical necessity for lactation services, and the applicable coding and billing guidelines that were made available. So let us begin with the provider types recognized for the reporting of lactation services when rendered outside of the CPSP. Registered nurses under the supervision of a physician, registered dietitians also under the supervision of a physician, and physicians, including OBGYN physicians and pediatricians, can bill for certain lactation services by reporting a medical office evaluation and management visit code for new patient office visits or established patient office visits, utilizing CPT codes 99202 through 99205 for new patients and CPT codes 99211 through 99215 for established patient office visits. And when billing for an FQHC or an RHC, a pending billing code T1015 may be applicable. Verification with insurance carriers on the requirement of this code must be made at the FQHC and RHC. T1015 is the code that represents the reporting of a clinical visit. You now may be wondering why international board certified lactation consultants, referred to as IBCLCs, were not included in the list of those providers that can render lactation services. Well, although Medi-Cal does recognize IBCLCs for the rendering of lactation services, verification must be done at the site level for the coding and billing protocols that pertain to IBCLCs. There are only certain diagnosis types that will support medical necessity for lactation services when rendered outside of the CPSP. Let us review the umbrella of those diagnoses. Medical guidance informs us that diagnosis codes that are related to persistent discomfort to the woman while breastfeeding, diagnosis codes related to milk extraction, diagnosis codes related to infant weight gain concerns, and diagnosis codes related to the sucking dysfunction of an infant will support medical necessity for lactation services, where Z39.1 should be appended as the secondary diagnosis when billing for the service under the mother. Z39.1 is the diagnosis code for care and examination of a lactating mother. Medical guidelines also inform us that they will reimburse for services billed under the infant when billed by a pediatrician when the diagnosis is specific to the infant, such as those related to infant weight gain concerns and those related to sucking dysfunctions of the infant. Additional billing guidelines provided by Medi-Cal are centered around the billing for services when provided by a registered dietitian. Medi-Cal advises that if a patient visits with a physician for a separate visit other than for lactation services and receives care from a registered dietitian for lactation services on the same date of service, the physician must then bill the evaluation and management office visit that reflects the combined level of service. Medi-Cal also advises that when a registered dietitian renders lactation services in the absence of a physician, Office Visit Evaluation and Management Code 99211 should be billed. Let us look at the general descriptions of the Office Visit Evaluation and Management Billing Codes to better understand. Evaluation and Management Codes, often referred to as E&M codes, are codes that represent services provided by a physician or other qualified healthcare professional that can also practice and bill for the care of a patient's physical health, such as physician assistants and nurse practitioners. E&M office visit codes are divided into two groups, one for the billing of new patients and the other for the billing of established patients. E&M office visit code selections are based on the complexity of a patient's visit and the documentation provided, and it can also be determined by the time spent with the patient rendering the care for the diagnosis being billed for. For information on how to select an E&M office visit code based on the complexity of a patient's visit, the American Academy of Family Practice, the American Academy of Pediatrics, and the American Medical Association offers a plethora of information and guidance on their websites. And now, fellow travelers, this brings us to the end of our travels on Lactation Lane, which ends this segment, the third segment of the National Office's review of their California Coding and Billing Guide. I hope you've enjoyed this journey. designed to provide insight on coding and billing for services under the CPSP and lactation services rendered outside of the CPSP. I have enjoyed compiling this information for you and presenting it to further support in your understanding of the many different nuances encountered with coding and billing for insurance carrier reimbursement. Now, although this brings today's presentation to a close, I'd like to remind you that this isn't the end of our travels, as there is one segment left to complete the review of the Coding and Billing Guide. Segment 1 provided a review of all Healthy Steps aligned services in the guide up until smoking and tobacco use cessation counseling. Segment 2 provided a review of psychotherapy services. Segment 3, this segment, provided a review of the comprehensive perinatal services program, including lactation services when provided outside of the program. And the final segment, segment 4, will review the new dyadic benefit and the community health worker benefit. Thank you so much for your interest in not only billing and coding for Healthy Steps Aligned services, but for rendering these services, as together we can achieve improved outcomes for young children and families. Together, we bring focus to the important interwoven skills needed for families to foster healthy child development and lifelong well being. And we must stand proud as we help transform the promise of pediatric primary care by promoting nurturing parenting and healthy development for babies and toddlers. I thank you for your attention, your time, and the opportunity to present to you today. Goodbye.